Hello everyone, my name is Zoya Khan and I'm one of the PGY2 internal medicine residents at Lakeland Regional Health. And today I would like to discuss a very interesting case with you regarding a 22-year-old male who had a history of atopic dermatitis and was on nemolizumab for control of it. He presented for a generalized erythematous rash all over his body and systemic symptoms including fevers, night sweats, and chills that began several days after receiving his Nemluvio injection. He was evaluated in the ER. He was sent home essentially with a methylprednisolone dose pack. However, after he went home, his blood cultures resulted positive for Staphylococcus aureus, and he was called back to the emergency department for admission into the hospital. When he returned, he was hemodynamically stable and remained afebrile. On his skin exam, there were multiple areas of dry, cracked skin on his flexor surfaces, but they were without ulcerations, abscesses, or extensive excoriation. His lab work was pertinent for a white count of 12, a SED rate of 18, and CRP of only 11, and his lactic was 2.0. His repeat blood cultures were positive for methicillin-sensitive Staph aureus. He was initially treated with vancomycin and then transitioned to cefazolin, and repeat blood cultures were negative. His echocardiogram was negative for any endocardial vegetations, and he was transitioned to oral linezolid and treated for 14 days with infectious disease follow-up. The reason this case is so interesting is because typically atopic dermatitis is linked to Staphylococcus aureus colonization, and invasive infections are typically reported in the setting of severe, widespread, or overtly superinfected dermatitis with extensive barrier breakdown. In our patient, his skin findings were mild, and this indicates that even minor barrier disruptions may be sufficient for bloodstream entry, enough for them to cause invasive infections such as bacteremia. This teaches us that systemic symptoms such as chills and rigors prompt an evaluation, and Staph aureus bacteremia should be considered even if you have a patient with mild dermatitis. The clinical pearls of this case include that mild atopic dermatitis can still cause methicillin-sensitive Staph aureus bacteremia, and that systemic symptoms plus dermatitis should prompt you to get culture and workup, especially if the patient is presenting with fevers. And biologic drug-related flares may potentially worsen barrier function.